Good afternoon. My name is Adrienne Scheck, and I'm an associate professor at the Barrow Neurological Institute, and I'm going to talk to you today about the ketogenic diet as an adjuvant therapy for malignant brain tumors. If you have any questions, please feel free to type your questions into the Q&A box, which I believe is on the left of your screen, and I'll either get to them during the talk or at the end of the talk. In addition, this is a CME accredited talk, so if you want CME credits, you can click on a button on your screen and you'll get credit. I do have to give a brief disclosure, and that is that some of the work I'm going to discuss was supported by a grant from Nutrition North America, and they provide Ketocal that we use for these studies. First, a few brief survival statistics about brain tumors. Brain tumors are a leading cause of death due to cancer in the pediatric population. In adults, there's a peak of incidence in 0 to 19-year-old people, and of course another peak of incidence in the older population, as is normal for most cancers. And you can see from these statistics that the survival is really very poor. And this survival is with the standard of care. That means surgery, radiation, and chemotherapy in the case of glioblastoma multiforme. One problem with brain tumors is they're very heterogeneous. That is, if you look at the cells from different regions of the same tumor, you can see that when you grow them in the lab, they can look different. If you look at the karyotypes that I'm showing here, you can see that at the genetic level, cells from the same tumor can be very different. At the molecular level, the cells can be very different. And in fact, that means their phenotype, in other words, their behavior, their invasive capability, their response to therapy, etc., is also different. And this is all within the same tumor. This makes treating them extremely difficult. One thing about cancer in general that's been found in the 1920s and is sort of resurfaced as a hallmark for cancer is that cancer cells tend to have aberrant metabolism. There's something called the Warburg hypothesis, and that came from Otto Warburg in the 1920s. And he said that cancer cells undergo aerobic glycolysis. In other words, cancer cells use high levels of glucose and glutamine for energy, but they get fewer ATP molecules than a cell normally would in the presence of oxygen. So they need lots of glucose and glutamine to get the ATP they need, and the remainder of the carbons are catabolized to make the building blocks that they need for cell proliferation. Virtually all cancer cells have aberrant metabolism in one form or another. Oncogenes, which used to be the main buzzword for cancer a number of years ago, they often regulate downstream targets that we now know are involved in metabolic regulation. So oncogene pathways are not just growth factor pathways separate from metabolism, but the two pathways actually intersect and overlap, and metabolism often controls some of these pathways. So if tumors use a lot of glucose, can you possibly starve tumors by simply reducing the glucose? And this is where the ketogenic diet comes in. And to call it a diet is really almost a misnomer because it's actually metabolic therapy. Yeah, don't do this at home, folks. This is something that really requires the assistance of a trained professional. It's a very high-fat, low-carbohydrate, low-protein diet. It reduces blood glucose and it raises blood ketones. And ketones can be an energy source for the normal brain. So if you reduce blood glucose, the brain becomes unhappy because the brain wants glucose. If you provide an increase in ketones, the normal brain and other normal cells can use that for energy. Tumor cells generally are thought not to be able to use ketones for energy, and thus you're basically starving them for energy. This mimics caloric restriction or fasting, and it's been used for years as a treatment for refractory pediatric epilepsy, so it's got a very long safety profile, and there's a lot known about the side effects, which are typically handled with over-the-counter remedies. It's also thought to be neuroprotective, so it's being looked at for Alzheimer's disease and other neurodegenerative diseases, and this may be due to the reduction of reactive oxygen species, but there's probably other mechanisms that are involved as well. So what is the potential clinical utility of the ketogenic diet in oncology? Well, as I said before, tumors may not be able to use ketones as an energy source. Normal brain and, in fact, normal cells can. So you can be protecting the normal cells from energy reduction while hopefully reducing the energy available to the tumor. Maybe this will slow the tumor growth. In the case of brain tumor patients often have seizures. This is known to be an anti-seizure treatment, so it could possibly reduce seizures in brain tumor patients. In addition, one hypothesis is that because it's known to be neuroprotective, perhaps, and this is a hypothesis, perhaps it would protect the normal brain from radiation damage. and it may protect the normal brain from some of the damage that sometimes comes from chemotherapy. When we first started doing this, we recognized that the standard of care for glioblastoma is surgery, radiation, and chemotherapy. And any additional treatment is going to have to be done in the presence of the standard of care. So alterations in metabolism really will need to be done as an adjuvant therapy if it's going to get to the clinic, and that was our goal. The first thing we did was we showed that using cell culture, and this is actually a cell line that is very autocrine, that is, it makes growth factors, spits it into the media, and uses it to help itself grow. So it's a cell line that grows extremely well. It's also grown in a very high glucose media, so these cells were not restricted in their energy source at all. And you can see that just mock treatment, the cells grew quite well. When we simply added ketones to the media, it reduced the cell growth. The patient this cell line came from was treated with BCNU, so we tested BCNU. BCNU, you can see, slows the growth, and then the cells that are resistant begin to grow again. But when we added BCNU and ketones together, we essentially killed the culture. So this first gave us some indication that ketones are actually having an effect on brain tumor cells, not just because of a reduction in glucose, but also through some other mechanisms. We've recently looked at whether ketones work with radiation in vitro. This is the work of a high school student in my laboratory, Alex Rossi, and we found that, again, control cells grow well. Control cells given radiation slows their growth. When we use beta-hydroxybutyrate, which is a ketone, it reduces their growth, and beta-hydroxybutyrate plus radiation pretty much wipes out the cultures. So in vitro, this seems to work. What about in vivo? We have an experimental protocol that we've used for all of our in vivo studies. The GL261 cell line is a syngeneic mouse malignant brain tumor cell line. It recapitulates many of the things that you see with a glioblastoma multiforme. We made these cells bioluminescent with the LUC2 gene, and these cells are transplanted into the brains of albino C57 black 6 mice. So we've got a syngeneic immunocompetent model that we can follow tumor growth using bioluminescence. The ketogenic diet that we use is Ketocal. Ketocal is a human formulation of the ketogenic diet. We provide it to the animals ad libitum, so we do not calorically restrict. We let the animals eat as much as they want. For humans, this can be considered a nutritionally complete diet, although it's typically used more as a supplement or as a base for recipes. It's got a 4-to-1 ratio of fat to carbohydrate plus protein, and this is, again, a ratio that's typically used for pediatric epilepsy. And what we do is we mix it in a 2-to-1 paste with water and provide it to the animals. On day 0, the animals have the cells surgically implanted into their brains. On day 3, we image them to determine the tumor size. They're randomized to treatment protocols, and then we check the blood BHB or ketone levels and the blood glucose levels. And these animals have a reproducible set of symptoms approximately 24 hours before they succumb to the disease. So when we see these symptoms, the animals are humanely sacrificed. And that's what the image looks like when you do the in vitro imaging. The computer gives us a color picture, but we also get a quantitative number of photon count to tell us exactly how much bioluminescence there is. And that is the, okay, hopefully you saw, I just pushed out a reference to you. The references are on the bottom of the screen. So this is what the growth curve looks like. You can see that with time, the tumors grow, and the in vivo photon count shows the tumors getting larger. The little inset there shows a brain immediately after sacrifice of the animal, and you can see that the bioluminescence is coming from that little dark circle, which is where the tumor is. Bioluminescence requires ATP, so essentially it only shows living cells. The little inset we were able to get only because we imaged immediately after sacrifice. Had we waited 10 or 15 minutes, we would not have seen bioluminescence. So this is an indication of live tumor cells. And following tumor growth, you can see that animals fed the standard diet, the tumors grow quite quickly. That little drop at the end is probably due to necrosis happening in the tumors. So the tumors, you're starting to see some cell death in the tumors when they get very large. But the animals on ketogenic diet, you can see the growth rate of the tumors is quite a bit slower. So what's the mechanism of this? The first thing we thought to do was to compare the mechanisms of the ketogenic diet to what we would call druggable targets. In other words, things that the pharmaceutical companies are looking at, again, to help make it more accepted in the clinic. The first thing that we thought was growth factors play a very important role in the growth of brain tumors. There's quite a few pharmaceutical companies trying to come up with inhibitors of various growth factors. So doing a microarray analysis, we found that insulin-like growth factor was indeed reduced in tumors from animals fed the ketogenic diet. In addition, two downstream targets, the RAS-P21 protein and MAPK8, were also reduced. This was at the RNA level. At the protein level, insulin-like growth factor was indeed reduced. You can see on the left-hand panel, the left side of that picture is a non-tumor containing brain. The right side is the tumor. There's a great deal of green fluorescence for the insulin-like growth factor, and the counterstain is DAPI for the nuclei. On the ketogenic diet panel, you can see the tumor. There's a lot of nuclei together on the tumor side. The non-tumor side, again, looks pretty normal with the nuclei spread out, but there's little, if any, insulin-like growth factor showing. Another thing that we found interesting was that other growth factors important in brain tumors, for example, platelet-derived growth factor, epidermal growth factor pathways, they also use RAS-P21 and MAPK8. So it's quite possible that the ketogenic diet is dialing down the overall activity of a number of growth factors in these tumors. Okay. As I said before, we use Ketocal because it's clinically relevant. We previously did some of the work with an animal ketogenic diet, which is actually a 6-to-1 ratio. The results were the same with Ketocal. The results actually are better, as I'm going to show you in a minute. There's a lot of recipes out there. It's much easier for patients to use. If they want to supplement, there's actually a liquid Ketocal version. So we now do all of our experiments with Ketocal. So we repeated some of the experiments we had done with a mouse ketogenic diet, and we've shown that using Ketocal, the panel to the left, the black bar is the ketone level in the blood on standard diet. The blue is on ketogenic diet. And then the red and the green are standard in ketogenic diet in animals that got radiation therapy. And the gray and the purple are the ketone levels in animals that got temozolomide therapy. And you can see that the Ketocal does indeed increase ketones. When we looked at the glucose, this was somewhat interesting. We expected to see a drop in glucose in the animals on Ketocal. And early on in the experiment, 6 days post-implantation, we did see that in animals that were on diet alone or animals that were on diet plus radiation. We didn't really see much of a drop in glucose in the animals on temozolomide. If we went 2 weeks into the experiment, approximately 13 days later, the difference in glucose disappeared in the radiated animals and in the temozolomide-treated animals, and it was less of a difference in the diet alone. We can't really explain that, but we find it very interesting in light of the data that I'm going to show you in a moment. The animal weights, just to show that they don't lose weight on Ketocal. The top bar is the diet alone. You can see the animal weights are the same. In the middle, this is the animal weights in animals fed standard diet plus radiation in green, and Ketocal and radiation in red. The asterisk on the green is one animal. So where the asterisk is showing, there's only one animal that is surviving at that point. That animal, for reasons that we don't know, calorically restricted herself. She dropped her weight. She stayed healthy, active, showed no indication of a problem, and that animal did outlive the other animals that were on standard diet plus radiation. So caloric restriction is effective, but we wanted to show that the Ketocal was effective in the absence of caloric restriction. Again, the idea being what's going to make it easier for patients. The animals on temozolomide showed a transient drop in weight and then on Ketocal, and that weight then came back up. So here's the survival plots, and this is why I think it's very interesting that we didn't necessarily see a major change in glucose, but we did see a difference in survival. The black line is animals on standard diet, and this is a combination of two totally separate experiments. So we had two different experiments, and we pooled the data to get these graphs. Animals on Ketocal had a significantly increased survival. Temozolomide increased survival over standard diet alone, but Ketocal plus temozolomide increased survival over temozolomide alone. With radiation, again, an increase in survival over animals on standard diet alone. But what we really found interesting was that animals fed ketocal and given radiation, actually, we had a tumor disappear in 9 of 11 animals. So using bioluminescence, you can see in the top panel, that's an animal that got radiation alone, and you can see that the tumor did indeed grow and the animals all died. The lower panel shows one of the tumors that we have that disappeared. And they all disappeared with time, some of them a little bit sooner, some of them at about day 40 or so. The black bar, which is difficult for you to see possibly, but it's right at about day 101, that indicates where we switched these animals back to standard diet, and these tumors did not come back. So switching the animals back to standard diet, we waited another 200 days, so the animals survived till about day 300, and there was no recurrence of the tumor. Upon sacrifice, the tumors could not be found. So we were interested in how this is working. Since the literature said that the ketogenic diet reduces reactive oxygen species, we did one early experiment looking at reactive oxygen species, and it looked like there was a reduction in reactive oxygen species in the animals fed the ketogenic diet when we looked shortly before the animals succumbed to disease. We thought maybe the reactive oxygen species actually peaked early and then came back down, so we used a chemiluminescent molecule called L012, so that allowed us to measure the reactive oxygen species in vivo. And you can see in this panel that the tumor does show an increase in reactive oxygen species over sham operated animals as expected. This is what we found in our tumors. When we looked at 24, 48, 72 hours post-radiation, at all time points, ketocal plus radiation reduced reactive oxygen species relative to what was seen in animals with radiation alone. So although the ketogenic diet seems to strongly potentiate radiation, at this point we don't think it has anything to do with reactive oxygen species. And in fact, it's a little bit of a conundrum why it reduces reactive oxygen species and does not reduce the efficacy of radiation. But this also is giving us a little bit of a suggestion that perhaps it would protect the normal brain from damage due to radiation. But again, that's just a hypothesis at this point. The other thing we noticed was that the tumor size at death in the animals that were on ketocal tended to be bigger than the standard diet, and this is a size based on photon count, so it's based on bioluminescence. The thought is that if what's killing the animals, or people for that matter, is essentially tumor burden, you can think of tumor burden as the tumor cells, but also anything else going on around the tumor, so any effects of inflammation, any effects of edema, all of that essentially increases tumor burden. And because our brains are surrounded by a skull, there really isn't any room for things to swell. So all of that contributes to the pathogenesis of the disease and the mortality of the disease. So if we have more bioluminescence in these animals, something else must be less. And we hypothesized that perhaps there was less edema. So we do have an animal MRI here, and this was done in collaboration with Drs. Greg Turner and Cheng Lu. And we did MRI on animals, two groups that had tumors of essentially the same size. They did an analysis of the MRI, and in fact there was a significant reduction in edema in the animals that are on ketocal versus the animals on standard diet. Looking at possible mechanisms of this, cyclooxygenase 2 expression was one thing we looked at. We had a hint that cyclooxygenase 2 was reduced from some RNA data we did using the animal ketogenic diet. So we repeated this using the human ketogenic diet, or the ketocal, and in fact you can see from the immunofluorescence here, the green being COX-2, that in standard diet there's quite a bit more COX-2 expression than there is in animals fed ketocal. And in these panels, all we're showing is the tumor. We're not showing any normal brain next to it. So ketocal seems to reduce the expression of cyclooxygenase 2, which would lead to a reduction in inflammation. In addition, we have the ability to look at this in vivo. There's a fluorescent probe put out by PerkinElmer called Xenolite, and it shows COX-2, and you can see the fluorescence of COX-2 in the mouse head there. So looking at a number of animals, some with radiation and some without, the ketocal reduced COX-2 expression in animals that were just on the diet, standard diet in gray, ketocal in blue. But also when the animals were radiated, there was an increase in the expression of COX-2, as you can see with the red bar, and that's expected with radiation. But the animals on ketocal did not see an increase in COX-2. So the COX-2 levels are kept down in animals on Ketocal, again suggesting that we're getting a reduction in inflammation and possibly a reduction in concomitant reduction in edema. The other thing we looked at was hypoxia. Hypoxia is common in brain tumors. There's usually areas of hypoxia. These areas are typically more radio-resistant because the radiation works better in an oxic environment as opposed to hypoxic. Again, there's a fluorescent marker that we can use called hypoxysense, which detects carbonic anhydrase. So looking at our animals on the standard diet and on Ketocal, you can see in the panel below on the left that the Ketocal significantly reduced hypoxia in these animals based on the hypoxysense analysis. And the panel on the right just shows that we were looking at a group of tumors that were approximately the same size. Looking at gene expression in a more quantitative way by a Western blot, you can see that the carbonic anhydrase 9, which is a marker for hypoxia, is significantly down. HIF1 alpha, which is gene expression that's increased in the presence of hypoxia, significantly down. NF-kappa B, which is a molecule that's involved in a number of pathways, including some of the pathways that are involved with hypoxia and various other aspects of tumor growth. There's no difference in total NF-kappa B, but there was a significant difference in phosphorylated or activated NF-kappa B, and this was work done by a high school student in my lab, Raj Vatsa. We looked at angiogenesis, the green fluorescence being CD31, which is marking blood vessels. You can see in the standard diet the blood vessel showing in the tumor. In Ketocal, that's just a representative screen. None was shown. And what we did was we quantitated the amount of green fluorescence in 10 random fields for standard diet and for Ketocal, and you can see that there is a significant reduction in CD31 immunohistochemistry showing in the blue bar relative to the animals on standard diet, which is the white bar. Again, Western blot recapitulates the immunohistochemistry. So we were interested in the mechanism. In discussion with one of our colleagues, Dr. Tom Seyfried, he said that with caloric restriction, he was seeing a reduction in vascular endothelial growth factor. We weren't seeing that in some of our early RNA data, so we went back with the Ketocal and looked again at vascular endothelial growth factor, which is a driver of tumor angiogenesis, and we did not see a reduction in our animals fed Ketocal. On the other hand, when we looked at the receptor, vascular endothelial growth factor receptor 2, we did see a reduction. So there is a slight reduction in VEGF on the left, but it's not statistically significant, whereas it is statistically significant difference in VEGF receptor. The graph on the right shows the expression at the RNA level of VEGF-A, B, and C. VEGF-A is thought to be the driver for angiogenesis. VEGF-B, the activity of that is not known really well yet in terms of what it's doing in tumors, but it was interesting to us that it is significantly down, and VEGF-C, there's no difference. So we think that the anti-angiogenic mechanism going on here may be more related to the receptor than the ligand. Again, looking at other markers of tumors, for example, metrometalloprotease, looking at invasion. We did an experiment, and I'm not going to show you the data, but we did an experiment called the scratch assay, where you can grow cells in a monolayer, scratch the monolayer, and then watch how long it takes for cells to fill that scratch. That can be an indication of the cells migrating or invading into that scratch. We did see a difference when we added ketones to the media. So using Western blots, we looked at matrix metalloprotease 2, and you can see that the pro version or the unactivated version as well as the activated form both are reduced in animals on Ketocal versus animals on standard diet. I showed you the MRI that there was a difference in edema, so edema and inflammation often go somewhat hand in hand. We looked at a number of mechanisms that may be involved in edema. The other thing that happens in brain tumors that leads to edema is the new blood vessels that are made, the angiogenic blood vessels, tend to be leaky. The blood-brain barrier capillaries, which are normally very, very tight, get loose and they leak, and that tends to increase the edema around the tumors. So we looked at some of the markers of the blood-brain barrier, including ZO1, occludin, and then aquaporin 1 and aquaporin 4. There was a significant increase in ZO1, which would lead to a tighter blood-brain barrier, in other words, more normalization of these blood vessels. We did not see a difference in occlusion, but we did see a apparent but not quite significant drop in aquaporin 1 and a significant drop in aquaporin 4. These markers are also being used to look at prognosis in brain tumors. So essentially, the changes that are happening would, if this was in the primary tumor, it would push it to a tumor that had a better prognosis. So these changes, again, are all good for the patient. So in summary of what I've shown you, essentially what we're seeing with the ketogenic diet is a reduction in HIF-1 alpha, a reduction in phosphorylated NF-kappa B, a reduction in VEGF2, reduction in matrix metalloprotease, ZO1, aquaporin 4, some of the genes involved in inflammation, and data I didn't show you is we've got a reduction in TEC. So essentially what the ketogenic diet is doing is it is changing gene expression, possibly leading to a reduction in angiogenesis, tumor cell invasion, and vascular leakiness and edema. So obviously these are all really important things in terms of managing your brain tumor. So the preclinical summary. Should the ketogenic diet be tested in the clinic? First of all, we've demonstrated that it has efficacy as an adjuvant therapy. It potentiates both radiation and chemotherapy in our mouse model. There's efficacy in the absence of caloric restriction. Would there be efficacy in the presence of caloric restriction? I'm absolutely certain there would be. We are doing all of our experiments in the absence of caloric restriction simply to make it easier for the patient to use it, easier to get patient compliance. The diet itself is somewhat restrictive and not easy to stay on, so we're trying to make it as easy as possible to demonstrate efficacy in patients. We see a reduction in peritumoral edema in our model system, a reduction in radiation-induced inflammation, reduction in angiogenesis, and potential value added that we haven't studied yet, but we plan to, is there's likely to be a reduction in seizures, and we think there's a reduction in growth factor signaling, and that work is in progress. So does the ketogenic diet have clinical utility? We think there's a resounding yes answer. There are case reports out there, anecdotal case reports and published case reports. The first one was in 1995 when Linda Nebling presented their data on 2 pediatric patients, both of whom were put on a ketogenic diet and both of whom did quite well, in fact far better than would have been expected from their diagnosis. There was a report at a meeting by Miriam Kalamian about a patient report, a case report about a young child with a brain tumor, and the ketogenic diet extended that child's life quite a bit. And then in 2010, there was a report by Zuccoli and coworkers describing the results on a 58-year-old woman with a butterfly glioma. And again, the ketogenic diet seemed to extend her life more than would be expected from the diagnosis. There's also a lot of anecdotal evidence out there. So if you go on Facebook, if you go on some other public media, there's quite a few people that are saying they've done this and it's helped. So that's led us to go for a clinical trial. Clinical trial personnel we have is Leonora Renda. She's a dietitian that works with our patients. She's excellent. She did a webinar for the American Brain Tumor Association. If you're interested, I invite you to go on their website and listen to it. It describes the use of the ketogenic diet for brain tumors. Narissa Honey, Dr. Narissa Honey, she is a research clinical nurse, and she's doing quality of life analysis and cognitive analysis on the patients and quality of life analysis on the caregivers. Doctors Lynn Ashby and Christopher Dardis are the neuro-oncologists at the BNI, and of course the Barrow neurosurgeons are strongly behind this. The clinical trial is for high-grade gliomas. We're doing 20 patients with gross total resection, 20 patients with a subtotal resection. We're looking at the ketogenic diet plus the standard of care, meaning temozolomide and radiation, using a standard Stoop protocol, so that treatment does not change at all. During the radiation chemotherapy, the patients are on a classic 4-to-1 ketogenic diet. It's administered by a registered dietitian that's got training in the ketogenic diet, and that would be Lee Renda at our institution. The patients are doing this with normal food and Ketocal as a supplement if they want it. The diet is administered with the use of something called the Keto Calculator. This is an online database. It's HIPAA compliant. It's free. The patients need to get a prescription from their physician. They're then registered on this database, and the dietitian and the patient can then work together to make meal plans and look at the different nutrients to maintain the ketogenic diet in a healthy way. And through the use of the Keto Calculator, Lee and the patient can work together, and calories and amount of food is altered as needed for the patient to feel good and maintain ketone level and glucose levels where we want them. We're looking at the tolerability of the diet. We're looking at overall and progression-free survival of the patients, quality of life of the patient and the caregiver, because this is a bit of a lifestyle to have to change food preparation. So one of the things that you hear from people who haven't done this is, well, it'll be too hard for people. It turns out that the patients that have been on this, many of them say they can actually do this, and it gives them the feeling that they're doing something to help themselves, and that's really important for patient quality of life. We're looking at changes in seizure activity and anti-seizure medications. We're looking at changes in steroid use. The neurocognitive tests, as I mentioned, are being done on the patients. We're doing daily blood ketone and blood glucose levels to monitor the diet effectiveness and determine if alterations are needed. So the goals that we have are to have the ketone levels above 3, preferably around 4, and glucose at about 70. Now, a number of brain tumor patients end up on steroids because of swelling. First of all, we're hoping that the ketogenic diet will reduce the need for this, but also it can be very difficult to maintain low glucose levels in the presence of steroids. I'll show you from some data that I'll give you in a few minutes that one of our patients was on that and actually was able to do it. So it might be a little more difficult, but it's not impossible. The patients are monitored for uric acid, cholesterol, triglycerides, LDH acidosis, and free carnitine. So these are the cases we've had to date. 2 of these cases are actually on our trial, and 3 of them are being followed outside of our clinical trial. You can see here the ages are ranging from 39 to about 63. 2 of them are not on steroids, 4 of them are. Total follow-up is pretty variable. Some of them have just started. One question that we always get that people really worry about is weight loss. People get very concerned about weight loss in tumor patients in general. And in fact, the weight loss that is seen on the ketogenic diet is absolutely not the same as the weight loss that's seen in cachexia. In cachexia, there's muscle wasting. It's a weakening kind of weight loss. The weight loss that we've seen in some of the brain tumor patients, as you can see from these numbers, it's relatively minimal, and it's not a muscle wasting type of weight loss. And in fact, the patients do tend to gain it back. We have quality of life analysis on one patient. Again, as I said, this is done by Dr. Narissa Honey. And the T1 is the baseline, so that's before these patients start treatment. T2 is at the end of their radiation therapy, which is about 2 months later. T3 is 4 months after baseline, and T4 is 8 months after baseline. Something I forgot to mention when I discussed the clinical trial, the patients are on the classic 4-to-1 diet during their radiation chemotherapy. When the radiation ends, we're allowing them to transition to what's called a 1-to-1 diet or a modified Atkins diet. This is a little bit less severe, but it still does help keep the glucose a little bit lower and hopefully the ketones a little bit higher. So that would happen right about at T3. You can see from these numbers, larger is bigger, and you can see if you just compare T1 to T4 that we're not seeing a major change in quality of life. The quality of life of these patients is not going down because of the diet. In fact, in some cases, it actually looks like it may even be going up a little bit. Again, cognitive aspects of quality of life, we're not seeing a decrease due to the ketogenic diet. Weight status. This was one patient that did lose weight at first, but she regained that weight. And her diet was initiated at about 1,200 kilocalories, and it was maintained at about 1,800 to 1,600. As best we can figure, the weight loss at the beginning may have been due to the fact that she was very fit, did quite a bit of exercise, and when she first got sick, she stopped exercising. So there was a little bit of a drop in weight. But once she got strength back and got back into a more normal routine, that weight was gained back. You can see that even though this patient was on high-dose steroids, Her blood glucose averaged at about 82. It ranged from 74 to 105, and the ketones ranged from about 5.4 to as low as 3. But they averaged about 5.4. But they went between 0.3 and 7.7, and even at 7.7, she reported feeling just fine. Cholesterol was borderline high, potassium a little bit low. The side effects that you tend to get with the ketogenic diet are usually manageable fairly easily. So cholesterol can usually be managed simply by changing the source of the fats, and constipation is handled with Miralax. Increases in calcium are handled with polycitrate. And with that, I'm going to just go to my acknowledgments and open the table for questions. I'd like to thank the people in my laboratory, Eric Wolf and Ken Brooks. Mohammed Abdulwahab and Katie Fenton are students that have done the majority of the work you saw. Katie Curley was a college student that did some of it. I mentioned some of the high school students that have worked with us. My collaborators, Philip Stafford, Greg Turner, Cheng-Wei Liu, Mark Poole, and Zhang Ro, who first turned me on to the ketogenic diet. And then our funding sources, the first being a really awesome group of students that worked very hard to raise funds, and they actually supported the work that was involved with us getting involved in the ketogenic diet in the first place. And with that, I'd be happy to open the door to questions. There's 2 questions I see typed. The first is, does KetoCal have any effect on TGF-beta and cytochrome C or apoptotic effect in vitro or in vivo? We haven't looked at TGF-beta and we haven't looked at cytochrome C, so I can't answer that. With respect to apoptosis, we haven't looked at apoptosis on KetoCal. When we were using the animal formulation, that is the 6:1 ratio, it didn't seem like there was a major difference in the number of cells, but it was very interesting that apoptotic cells seem to be somewhat distributed in the animals on the standard diet, and they seem to be a little bit more focal in the animals on the ketogenic diet. But we haven't actually looked at anything quantitative. The second question is that effect related to tumor grades or staging? I'm not sure I know what you mean. If you're asking whether the effect of KetoCal is related to tumor grade or staging, our animal model is a model of high-grade malignant glioma. It's invasive and it shows a lot of the hallmarks of high-grade tumors. So the effects we see there are not related to grades or staging. With respect to some of the work being done in the human population, our clinical trial is all in patients with very high-grade tumors. There is some work being done in the UK on patients with lower-grade tumors, mostly if those patients have seizures, and if the seizure medications are causing side effects. Some of these patients are switching to the ketogenic diet for seizure control, and they're going to be followed for their tumor growth and progression-free survival. So if that doesn't answer your question, please just retype it. Are there any other questions? Well, if there are no other questions, I guess I'll sign off. If you think of other questions in the future or you'd like to contact us, please feel free to contact me. You can see my email address at the bottom of this. I'm also going to push out a few, I'm told you should be seeing a pop-up with some reprints of some of the work I've shown you. These are all available through PubMed and through the various journals. And with that, I'll sign off. Thank you very much for your attention.